And now we're going to hear from Dr. John Pagel, who's chief of the Hematological Malignancy Program and director of stem cell transplantation at the Swedish Cancer Institute in Seattle, Washington, and a member of the CLL Society's Board of Director and Medical Advisory Board. It's my great pleasure to introduce Dr. John Pagel.
Well, hello, good to be with everyone. Thanks for joining us. We're going to do a little discussion here, of course, about immunotherapy, which I'm sure you're well familiar with in many ways, and this, what I would call a new paradigm for treatment. I trust that you'll find this interesting and informative, and I hope you'll have lots of questions when that time comes. Certainly, I think this is an exciting area for us to focus on as a game-changing approach using the patient's own immune system to tackle their CLL. So let's do that. Really, not that long ago, we had some approaches that we had been using for decades that hadn't really significantly changed. When you look at the CLL toolkit, we had chemotherapy agents and we had radiation therapy. And we generally applied those principles to really any patient who had CLL. Of course, that evolved not that long ago to include antibody therapies. Those are immunotherapies. Antibodies, of course, we make in our own body to target infectious organisms, often bacteria as an example. Well, we can, of course, make antibodies in the laboratory to target CLL cells. And in particular, the game-changing antibody has been known as rituximab. It's an anti-CD20 antibody, meaning it targets a marker on the surface of the CLL cell called CD20. And that's immunotherapy that's been applied to B-cell malignancies across the board. Remember, CLL, of course, is what we call a B-cell malignancy. So it's a B lymphocyte that we're targeting through CD20 with rituximab. And that's been a game changer in therapies, perhaps in other lymphomas slightly more than CLL, but been very, very important. So rituximab has markedly increased the outcomes for patients who have non-Hodgkin lymphoma, and these can really be applied to patients with CLL. And I want to remind everyone that CLL is really a non-Hodgkin lymphoma. So as I go through the next several minutes here in discussion, and if I'm talking about lymphoma, I'm talking about CLL as well. The principles and approaches are generally the same. And I'm going to tell you some data here around therapies evolving in the field of non-Hodgkin lymphomas, and in particular indolent non-Hodgkin lymphomas, that will be more specifically applicable to CLL in the near future. So now, of course, not only have we had chemotherapy, radiation, rituximab, again, rituximab being an antibody-based therapy, but we're emerging with cellular therapies as well. Cellular therapies are this whole concept of using the patient's own immune system to target the cancer, in this case, hopefully target CLL, and to hopefully work towards eradicating the disease. That's what, of course, CAR T-cell therapy is, which we're focusing on large part here. But I'm going to tell you about some other therapies, other antibody-based immunotherapies, and of course, also we now have targeted therapies. You know, of course, that these have also been game changers in CLL. We've, of course, had a long now run with ibrutinib, now more recently acalabrutinib. On the immediate horizon, there's a drug known as zanubrutinib, and there's others in development that are continuing to improve on the landscape of targeted therapies. I'm going to mention that briefly at the end of this discussion. So all of these agents, these in particular, antibody-based therapies, cellular therapies, and targeted therapies are tools in that CLL therapy toolkit that we can use in specific ways to target CLL cells and to kill those cells. Again, our approach is not chemotherapy per se, in large part, or even, of course, radiation. It's cancer immunotherapy, and you, of course, read about this all the time. It's not exactly new now. Been on cover of Time magazine here back to 2013 as the breakthrough of the year. It's been all over New York Times, other publications, and you may know someone or even yourself who's been actively involved with cancer immunotherapy. Immunotherapy is really an idea to use your own immune system, or I should say the patient's own immune system, as great potential to fight the CLL. And of course, when we talk about it that way, we understand that our immune system has somewhat failed us at baseline. Why is that? Well, it's failed us because a cancer has emerged, because those cancer cells like to camouflage themselves. CLL cells like to camouflage themselves or hide from our immune system. And how do they do that? Well, those CLL cells look very, very similar to normal cells. And we have a very sophisticated mechanism to keep our immune system largely from attacking our normal tissues and our normal cells. We don't want our immune system to kill normal cells. We want it to kill those bacteria or those invading organisms, or in our case, we want it to recognize CLL. And so we have to figure out mechanisms or ways to remove the camouflage or to get the CLL cells from continuing to hide. And there's all kinds of sophisticated mechanisms about how we might do this. I won't exhaustively go through this cartoon here, just to say it's important to recognize there are many different pathways and avenues for recruiting and facilitating what we would call effector cells to fight and deal with the CLL. Those effector cells are the patient's own immune system cells. So they are cells like T cells. In fact, T cells are probably the most powerful cell that we have in our body. You can see those cells on the upper left, the cytotoxic T cell, CTL. It's CD8 positive, means it has CD8 on the surface of it. It's just a marker, a protein. And we recognize that we can use those types of cells as a way to kill CLL cells if we can educate it, play a trick on it, so that we'll actually find the CLL cells, so that it can find those hidden cells or those camouflage cells. And there's a variety of other ways to do it as well. And we understand that this is a new paradigm. It's using the immune system as a way to improve outcomes and cures for people with systemic malignancies like CLL. This is a total paradigm shift in our understanding of how we approach patients with CLL and cancer. So to summarize our old era in immunotherapies, and evolving immunotherapies, our therapies in the past like radiation and chemotherapy have been very non-specific, not targeted, or not using the patient's own immune system well. We've certainly have had allogeneic transplants, which can be the ultimate immunotherapy. So remember, an allogeneic transplant is to take the immune system from a donor or somebody who's not the patient, introduce that into the patient, and use those immune system cells from the donor to hopefully target the CLL and eradicate it. Allogeneic transplants are things that we still do. That's really, again, what I would call the ultimate immunotherapy. And we've used a variety of other mechanisms, relatively nonspecific, to try and stimulate the immune system in the past. So proteins, hormones like interferon, even vaccines that we've tried to develop, all of these to try to mount an immune response against a specific malignant cell like follicular lymphoma or diffuse large B-cell lymphoma, where we've had most of our successes, Hodgkin lymphoma, or of course, even as we'll talk about more in depth, CLL. That's been the old era. We also understand, of course, that immunotherapies do, again, as I've said, come in many shapes and flavors. I'll focus here on antibody-based therapies here first. Remember, antibodies are made in the laboratory. They're typically delivered intravenously. Some of them now are delivered under the skin, subcutaneously. And also we recognize that these are what we would call an off-the-shelf way to provide immunotherapy to a lymphoma or CLL patient. Off the shelf meaning that those antibodies can be produced in large volume, and then they can be actually delivered to the patient directly off the shelf. Of course, when we give those antibodies, they're kind of recognized as those green kind of Y-shaped proteins on the right. They're designed to target a specific marker on the surface of the CLL cell. In this case, it's actually a marker that we commonly call CD20. We talked about that. That's what rituximab interacts with. The type 2 second generation antibody, obinutuzumab, targets CD20. But there are other targets that are emerging as well. One that you'll hear more about is CD19. So this is a way for us to interact directly with the malignant cell with targeting by the antibody. And that antibody then works in a variety of different ways. One of the ways, of course, is that it actually kills the cells directly, but it also can recruit the patient's own cells to be activated, and those immune system cells that are activated, like T cells, dendritic cells, macrophages, monocytes, these are all immune system cells, can then be recruited by the antibody and then stimulated or activated to kill the CLL cell. The other immunotherapy type are cellular immunotherapies. So the first I said were antibody-based therapies. Now we have cellular immunotherapies. And I got a little ahead when I switched to this slide, but no, these are ways to genetically modify the cells, your own patient-specific cells, where we can actually play a trick on those cells, as I've said, educate them so that they now become a living drug that we can give back to the patients as they've been engineered. This is the whole concept behind CAR T-cell therapies. They're not off the shelf. They take some time. So on the left, you can see what we do is we isolate those cells from the blood. We go and engineer into them what we call often a CAR, Chimeric Antigen Receptor. It's a piece of genetic material. In particular, it's DNA that we introduce into the patient's T cells in the laboratory, so that when that genetic material gets into the cell, it will make a protein that gets expressed on the surface of the patient's own T cells. That is the CAR. The CAR stands for Chimeric Antigen Receptor, and it's something that we then take those cells, grow them up into large numbers, and reintroduce them to the patient. They've now been educated, so to speak, so that they'll find the CLL cell and hopefully eradicate it. I'll talk a little bit more about the CAR in just a bit more detail in a moment. So you understand that we have two big classes. Antibody therapies or cellular therapies as our immunotherapy types. And what we might use in one setting, it might be very different than how we may treat a different CLL patient. And often we use these therapies in combination. So we have a new era. It's antibodies. You'll hear about something known as checkpoint inhibitors. I'll talk more about that in a moment. We have, of course, a lot of different other antibody approaches. We'll talk about CAR T-cell and cell-based therapies. And I'll briefly touch on combinations or targeted therapies here at the end. So let's just say a few more words about antibody-based therapies, and I'm going to focus on the newer approaches that may be very new to you. You also already know, and I've alluded to it, that there are anti-CD20 antibodies. We use them frequently in CLL. Certainly obinutuzumab, rituximab. We have another one that's not listed here known as ofatumumab, approved in CLL. It's rarely used. Emerging is another new antibody known as ublituximab. Nothing new and different from any of those anti-CD20 antibodies that I told you about and their mechanism in the last few slides. There's an antibody emerging targeting CD19. It's not approved in CLL yet, but it's known as tafasitamab. And the beauty of that is that it targets a different marker, a different antigen, CD19. PD-1 inhibitors are not new. They're not largely used in CLL to this point, but we're examining them and figuring out how to use them. There's two major ones, nivolumab and pembrolizumab. And the idea here is that they inhibit or bind to a marker on the surface of the cell known as PD-1. PD-1 interacts, drives an interaction between the malignant cell and the patient's own immune system cells. It's actually a way for the immune system cells to put the brakes on so they actually don't kill a cell that they're bound to. Those CLL cells are tricky. Those CLL cells will actually often express what we call PD-1 so that they look like normal cells, and that is a signal to turn off the T cells that may bind to them, and so they don't kill them. If we use an antibody like nivolumab or pembrolizumab, we can interact and disrupt that interaction between the T cell and the malignant CLL cell. We won't turn off the T cell, and it'll allow those T cells to actually be activated and kill the T cell. More about that at another time. We have now interesting new targets. CD47 is something you're going to hear more and more about. The data is mostly now to date in non-Hodgkin lymphomas, but we're getting data in CLL excitingly very much as well. And now we have what's called bispecific antibodies, where we target CD3 on the surface of the patient's own T cell and CD20, which is on the surface of the CLL cell. A variety of those in advanced development, and their big advantages to off-the-shelf delivery of an antibody that not only will target the CLL cell, but will bring the T cell through CD3 in close interaction with that CLL cell and allow it to kill the CLL cell. CD47 is an interesting molecule. It's on the surface of cells that we call macrophages. When CD47 is interacted with a cancer cell, the cancer cell is smart. It's telling that macrophage, that immune system cell, not to eat it. It's saying, don't eat me, don't destroy me. And why eat? Because that's how macrophages work. They're like a Pac-Man. They like to eat the malignant cells. So if we can block that interaction, you can see Pac-Man in panel B is going to actually allow for what we call phagocytosis, or eating. So we want to block that don't eat me signal that's on the surface of a CLL cell. And we've done that in a variety of settings. Here's a patient that we treated early on with CLL. It's showing that on the PET scan at the lower left, a very active hot lesion was treated with this bispecific antibody, and you can see that that's gone on the right-sided PET scan image. The lesion response change in the volume or burden of the disease goes down over time. Patient achieved a complete remission, and it's very exciting. Look for more of this soon. More about bispecific antibodies. I told you how this works. One portion of the antibody binds to the tumor cell, maybe a CLL cell, and the other portion binds to the T cell. So it's a way, again, to activate the immune system cells and bring them into contact with the CLL cell and allow it to kill it, something we call lysis, or releasing what we call cytotoxic cytokines or chemokines, which are small little molecules that will kill the CLL cell once it's activated and brought into close proximity to the T cell. Many different bispecific antibodies in development. Many of them are in advanced development. I won't belabor all the differences here. There are largely differences in just how the antibodies are constructed, but the concept is the same throughout. Perhaps the most advanced one to date is one known as mosunetuzumab. It's now been presented in a variety of settings. It's in advanced development in primarily indolent lymphomas, and we'll see it, or a variety of these, in CLL very soon. If you just look at patients with non-Hodgkin lymphomas, really not focusing on CLL here, but diffuse large B-cell lymphomas, transformed follicular lymphomas, mantle cell lymphomas, you can see even in patients who had prior CAR T-cell therapies that many of these patients have dramatic responses to the treatment. This is something we call a waterfall plot. Each of those vertical colored lines represent an individual patient's tumor burden and the change after therapy. So if the bars are going down below the horizontal axis at 0%, those are all tumor reductions or a reduction in the burden of disease. You can see a small number had an increase in disease, and a very high-risk, difficult patient population was response rates that are really outstanding, and lots of people getting what we call CRs, or complete remissions. Even more impressively, if you just look at the patients who have the most aggressive types of lymphomas, diffuse large cell lymphomas, this is also very, very active. So we have antibody-based therapies. I told you about a couple of exciting ones on the horizon. We still have got a lot of work to do, but generally these are extremely well tolerated, very manageable adverse events or side effects, and we're making super long, promising steps forward, not just in lymphomas, but CLL as well. And I'm excited about the development of those antibodies as, again, we gain more information. Now a little bit on cellular therapies, and in particular, I want to talk about autologous CAR T-cell therapies. I'll mention T-cell therapies that are actually not using the patient's own T-cells, but using a donor's. Those are what we call allogeneic T-cells. And sometimes we actually even engineer specific other allogeneic cells called natural killer cells, or NK cells. We have access to all of these kinds of agents, and they're exciting in that they all are highly active in B-cell malignancies. Most of the work has been done in diffuse large cell lymphoma or transformed follicular lymphoma, some now in mantle cell lymphoma, but we're doing studies, and I've treated many people with CLL with these types of approaches, and I've had game-changing results for people that haven't had those options, but they're only in clinical trials to date. So how do these actually work? Well, the idea is that you would take a patient's own immune system cell. That's the most important, powerful cell that we have, and in particular, that's a T cell. And we take that T cell, recognizing that it's very active, but we want to play a trick on it, as I've said many times, so that it will interact with the tumor cell and cause a process we call apoptosis, or cell death, kill the cell. But again, we have to play a trick. So we introduce into those cells something we call a CAR. Dr. Siddiqui is talking much more about the details of the data that we have in CLL, but know that it's a general principle as shown here, that we introduce into the patient's own cells this chimeric antigen receptor. The yellow horizontal bar in this cartoon represents the surface of the patient's own T cells. You can see that this protein gets expressed through the membrane of the T cell. The upper portion is the extracellular domain outside the cell that interacts with the CLL cell. And there's an intracellular domain inside the T cell that gets activated, that turns on the T cell once it's bound through that extracellular portion to the CLL cell. So it's very simple how it works. It's a way to make the tumor cell and the CAR T cell interact that we couldn't do because, again, those tumor cells were hidden. They were camouflaged before that time. So a little more detail. We take T cells out of the patient's own blood, or we take them from a donor. That's an allogeneic approach. We're just starting that process. We take the T cells, we take them to the laboratory, we introduce into them a CAR, or a gene that encodes the protein for the chimeric antigen receptor. Those cells then express the CAR on the surface of the cell or through the membrane, as I showed in the last slide. We grow those cells up into large numbers, and we reinfuse them back to the patient. It's a process that we've now been doing for several years. We've been lucky enough to be involved in it from the start. It works. Unfortunately, it doesn't work in all of the patients. We're certainly learning more and more and doing better and better, but it has a very predictable adverse event profile, toxicities, and we understand in the right patient, it might be appropriate and it might be significantly valuable for changing the natural history of a patient-specific individual disease. Let me just introduce some data that you'll hear more from Dr. Siddiqui on, knowing about CLL-specific CAR T-cell treatments. One of the more interesting ones just presented at the American Society of Hematology meeting in 2020 was the Transcend 004 data of using this CAR T-cell treatment, lisocabtagene maraleucel, in relapsed refractory CLL patients who had had prior treatment with a BTK inhibitor, ibrutinib, at some point or the other. Relatively small numbers of patients, but just to show you, this is very, very powerful. You get a little bit of lymphodepleting chemotherapy. We use a drug called fludarabine and cyclophosphamide, and the idea of lymphodepletion is to deplete somewhat of the immune system cells in the patient before we give those cells back so that the cells that are redelivered are not rejected. And then you can see these cells are extremely powerful, leading to response rates, ORR, overall response rate, of 80% or more, including patients who are refractory to prior Bruton tyrosine kinase inhibitor or venetoclax. You can see that provides meaningful DORs, or duration of remissions. You can see up to 18 months follow-up with 50% of patients not yet relapsing. And sometimes we can actually even look all the way down at the DNA level for a CLL cell and eliminate what we call minimal residual disease. And many patients, at least 2/3 of the patients, can become MRD undetectable in the bone marrow and in the blood. A very exciting, powerful approach. Another approach also presented at 2020 ASH was using the same type of therapy, but in combination with ibrutinib. So they're on ibrutinib at study enrollment, and they're actually continued on it through the therapy. Outstanding overall response rate from this CAR T-cell treatment of close to 100%, with about half of patients having complete remissions and large numbers of patients having undetectable minimal residual disease. We can see some toxicities, things we call cytokine release syndrome, neurologic adverse events as well. They're very predictable. We manage them well. We can get people through this. This isn't ready for every single patient who has CLL, and most patients won't need this, as you know. But in some settings, find a trial and look for something like this. It can be a game changer. I just want to mention that there are lots of different ideas and thoughts around cellular therapies. This is just the beginning. No question about it. Lots of different potential cells. Cells that we can, of course, implicate and utilize in our therapies. Allogeneic cells, autologous cells, NK cells. Look for more and more exciting data to really change the natural history of CLL. I'll just spend lastly a few brief minutes on targeted therapies because it's not the focus of what we're doing, but do know we have targeted therapies like ibrutinib, acalabrutinib that hit a target in the B lymphocyte that are now newer therapies emerging and evolving. Again, a lot of fun cartoons here, but know that targeted therapies in CLL have largely revolved around BTK inhibitors, some use with PI3 kinase inhibitors, certainly venetoclax and BCL2 inhibitors, and now we have several more emerging, which I'm going to talk about here in just at least one of them over the last minute or so, and that's LOXO 305. Maybe you've heard about LOXO. It does target Bruton tyrosine kinase, just like ibrutinib or acalabrutinib. The idea, of course, is that we can actually inhibit what we call B cell signaling, and that stops proliferation of the cell and induces cell death. A little complicated on the slides, but know that LOXO is now a newer version of this. It's one that actually cycles on and off of Bruton tyrosine kinase, and that allows us to get very high sustained peak drug levels that don't fluctuate significantly. We've now done a dose escalation study. It's ongoing, but the early data in a very, very difficult group of patients is outstanding, not just in CLL, but mantle cell lymphoma and other lymphomas as well, with high response rates. And some of those can be quite durable. We recognize that there's a variety of others in development. One other that you'll look for is one known as ARQ-531, ARQL-531, also outstanding data there, as we also see with LOXO 305. So what's unique about those agents, or these, is that they actually even look like they can work in people who are now no longer responding to the early BTK inhibitors like ibrutinib or acalabrutinib. They actually can rescue, in many cases, patients who are refractory to those early BTK inhibitors, ibrutinib or acalabrutinib. It may allow us to continue treating with a BTK inhibitor despite the fact that the first ones didn't work. Now we're seeing data, and I've got firsthand data to show that these agents like LOXO 305 can rescue people, get other remissions after you've stopped responding to ibrutinib or acalabrutinib. So now we have this toolkit. It's pretty exciting. Cellular therapies, antibody-based therapies. You know about targeted therapies, a lot of those exciting and new and evolving as well. The future is super bright for patients who have CLL. No one wants CLL. I get it. I don't want any patient to show up with CLL. It's not something we like to see, but we do understand we have a nice toolkit that's growing, and it's going to be game-changing for our patients. These are the agents that we're excited about. We're also excited about the ones that we don't even anticipate and understand to this point. Very good, exciting data, and I thank everybody for their time. I work with a lot of tremendous, smart people who are excellent in the care of patients with CLL. A big team that I'm lucky enough to be with, and I'm lucky enough that I got to join you on this presentation today. Thank you very much.